Right, hello and good evening, everybody. Thank you for joining our webinar number two as part of our webinar series. We are delighted to have lots of great people on here. Um, we just want to make sure everyone can hear me now that we're live. Phil, can you hear me? Perfect, that's great. Just a bit of house admin before we kick off. So the webinar is being recorded, and it will be available on the public domain. And if you don't like your picture on there or your video, we'd ask you to switch your video off for privacy reasons. In addition, if anyone needs captions, there is a caption option. If you go into more, click on language and speech, and then click on live captions, you'll be able to see the captions of the webinar as we're going on. Um, Finally, I'll introduce the program to everybody, but at the end there will be a Q&A, and you can ask questions through the chat function, and Phil Tozer will be moderating that. You can ask questions during the webinar as and when they come, and then we'll sort of go through them in the Q&A section. So just a quick overrun on the webinar today. The program, we have the wonderful Sister Denise from St Mark's, who is a specialist fistula nurse, and she's going to be talking about post-operative management, wound care, and particularly digitation. We then have Mr. Alex Leo, who is a consultant colorectal and pelvic floor surgeon, who's going to talk about fistula and the challenges of continence related to fistula surgery and fistulas themselves. And then we've got Kapil Sahnan, who's a consultant colorectal surgeon at St Mark's, who will be talking about the role of imaging in the fistula disease and also recurrent disease and further fistula repair attempts. And then at the end, the Q&A is going to be moderated by Phil Tozer, who again is a consultant colorectal surgeon at St Mark's and also the clinician lead at our Fistula Awareness Steering Group. Right, so without much further ado, I think everyone is here to listen to all these wonderful people. I will hand over to Sister Denise. Sister Denise, are you there?
I'm here, and thank you very
Fantastic.
much for inviting me. So, Sal's going to be my glamorous assistant, and we're going to start from slide one, please. Um, Top slide.
I'm not doing a great job at being a glamorous
You're
assistant,
not a
am I?
very good assistant at the moment.
Right, here we
So,
go.
here at St Mark's, what we do is digitation of the perianal fistula wound post-operatively, and this happens very early in the post-op journey. So if we can go to next slide now. So what is digitation? It's essentially putting a finger in your wound, giving it a wiggle and a sweep, and it's to keep the external part of the wound open and to encourage healing to take place from the bottom of the wound up to the surface. This prevents pockets forming and breeding points for abscesses. That's it. That's digitation in a nutshell. That's what I tell every patient. Next slide. This is what we use to tell the nursing staff what it is. It's the use of a finger to examine and break down any adhesions, internal granulation, which are potential areas of pocketing of wound exudate, which can lead to abscess forming and delayed healing. There's not much difference in it, and all digitation it's about using your finger. Hence, it's called digitation. So the next slide, please. Not much on these. The when and why of digitation. We advise twice daily, after your morning poo, and just before bed in the evening. It's a routine. You've got to get into it. Means that you're taking control of your wound and your wound care. It shouldn't take more than 10 to 15 minutes, and that includes the shower, the digitation, the drying off after. And it also means that you're not going to visit your practice nurse. You're not going to have district nurse visits. You're not tied down to other people's schedules, so that, you know, some people like to see their practice nurse maybe once a week or once a fortnight, and that's just purely to check that the wound's not infected. And because most of our patients are not local to the area, and a 2 to 3 hour journey here is not sort of feasible in most cases, but we do like to have the first visit with the nursing staff, because we can chat through a lot more of your wound care and how to look after yourself, not just about the digitation. So we do a lot of sort of psychological support, really, and I think that's the big thing that we can offer. And we are available by email, and I was going to say telephone, but we're never in the office because we're always working and we're always doing digitation, so we don't want to hold the phone and do things. Next slide, please. So who's to digitate? We have all of our patients digitating after they've had fistula surgery. And that even goes for the patients that can't bear to touch their wounds. We can teach them the bar of soap method, which is using the corner of a bar of simple soap, back to Prof. Phillips's day. But even these patients will end up digitating. Maybe eventually, it may be 2 years down the line, but we do get them digitating. And as I say, it can take a while for some people to be able to touch their wounds. They don't like the sensation. But it's rare that you're going to cause a problem to your own wound. You'll stop before it hurts too much. Next, please. So what to look out for? You know, if there's a problem with your wound, it'll be an increase in pain, rise in temperature, smellier discharge, more discharge, just not feeling right. That means you either get in touch or you get in touch with your GP to get a course of antibiotics. And it's as simple as that. What we don't want you to do is to sort of hold off going, oh, I've got an appointment in 3 weeks, so I can wait until then. You can't. It's better to nip these things in the bud. And when we are doing digitation, as I say, it's one finger. Mine are short and fat, so I sometimes use just my little finger, which is nice and skinny. But more often than not, that's all you will need to use. Now, my next slide is just saying that I've got a couple of sort of nasty looking wounds coming up, but this is the starting point of one of our complex fistulas, and this shows that how we can go from a very complex wound to actually no fistula being there at all. So next slide, please. So as I say, the next 5 slides show the complex healing of this fistula wound. The patient has given us permission to use these images for education purposes. Now, the first slide, if you can now, I think it'll take me about 3 minutes to get through these if you don't want to look. So shut your eyes. So next slide, please. So this patient was sent home from hospital here, and a week after surgery, this is what the district nurse telephoned us with, and a photograph. It was horrific. And this is the cleaned up version of it. It was, they had no idea on what to do with these wounds. So we got them taking photographs, we were talking to them by telephone, we were emailing any information that we could over to them. But this, you know, this wound is bruised, it's mucky. There's a seton suture right deep down there that you can see a rogue hair. Don't know whose that is because it's patient's not that colour hair. She had so much pain, lots of offensive discharge, and she was on cocodamol, Oromorph, unable to sit down. She couldn't walk very far, and it was just horrible. Next slide, please. They get better. This was 7 days after that first. And this was what we'd done was intensive input from the district nurses. We'd given specific training to 4 nurses by telephone, email, and what to do with the wound, how to clean it, how to assess it, how to digitate it. These nurses hadn't digitated a wound before either. And how to identify any problems that were sort of going to happen. She was still unable to move easily or sit around, and she was still on cocodamol, but she dropped the Oromorph at this point. Next slide. And it gets better. This was 10 days after the first contact, or 3 days after that second contact. And all the swelling is going down, wound contraction is evident, it's cleaner, it's drier, the suture's now visible. She's able to mobilize, she's able to stand up, she's able to go out for a walk, but she's still unable to sit down, and she's still on the cocodamol. What we want you to do is, if you're in pain, you take your pain relief, and if you think that your wound is, a little bit more sore than 2 paracetamol, you need to ask for stronger pain relief from either your GP or from your surgical team. So 3 months after first contact, this is a lovely little wound now. Huge improvement, more wound contraction, healthy granulation tissue. She was able to self-care this wound. Yes, it's taken 3 months to get here. She can sit for short periods, but she's developed a lot of skin tags. But she's only on paracetamol PRM for pain. So a couple of times a day, if that. All her little blue stitches have fallen out from around the wound, and it's clean and nice. Next slide. It's decreased in size again, and this is at the point when it was discussions for a full repair of this fistula with Mr. Tozer, I think it was, and it was several months later. Next slide, please. So we've still got a seat on in, but there is no fistula to see as such. If you can, from that first fistula picture, she's back at work. She went on holiday. She's still taking paracetamol PRN, but she's fine. Next slide, please. She had a flap repair, fully healed fistula, and discharged from service. And that's going from a pretty nasty looking fistula down to having no fistula. And, that's one of the worst case scenarios. Most of our fistulas that we see are not like that. Some are, and most of the time it is those persistent little fistulas that are those irritating ones that you'll think, oh right, we've got it under control, and then they'll get another infection, then they may have to go down to theatre, have another drain, have it drained out, another seton change. But the same care and the same information is given to the big fistulas as the little fistulas, and that is about digitation. It's about doing that from normally 1 or 2 days post-surgery. What we get people to do is use the shower head, get it up close and personal, nice warm water jet in there, and do that for a few days until you get to see the nurse to be able to then do your digitation training. And I love my job. I have to. And what we're in the process of doing at the moment is not just me. I've trained up Sister Raki here. She's been with me for over 2 years now. I'm starting to train a staff nurse as well. But it's a slow process to train staff to be able to spot the telltale signs of infection, of any problems, and to deal with the psychological impact of these wounds as well. Thank you very much, Sal.
Oh, thank you so much, Sister Denise. I know we can't see everyone's webcam, but we'll just give her a round of applause.
Thank you.
Thanks for sharing all that very useful information. Um, if anyone does have questions for Sister Denise, please pop them in the chat, and when we get to the Q&A, Sister Denise will very kindly answer your questions. Just to remind everyone on questions that I know everyone will have their own one-on-one cases, and this can be quite a challenging condition. But all the sort of medical professionals here are not answering your are not giving you medical advice on a one-on-one basis. So if you can just be mindful of that, but you're very welcome to ask questions, and they will answer as generally and as best as they can, but without giving any individual medical advice. Great, thank you, Sister Denise. I've also completely forgot the running order in my head, but I think what would be a nice follow-up after that is, you've had your surgery, you've had your recovery, but unfortunately your repair attempt has failed. So Kapil Sahnan, consultant colorectal surgeon at St. Mark's, will talk about imaging in fistula disease, and also recurrent disease and further repair attempts. So, Kapil, if you're okay to kick off, I'll hand the mic over to you.
Yes, thank you. And thanks, Denise. It's always brilliant to see what happens after we finish our operations and how well you manage really difficult wounds for people, not patients, for people, anybody to have. So fantastic. So this is a slide. It was the opening slide of the talk I gave today to a number of surgeons who came to St. Mark's, which is where I work. And it was from a paper, I think in about 2005, but it was fascinating. For the first time, it made this really complicated bit of anatomy and this condition slightly easier to understand. So 1A is a transsphincteric fistula. You can see the fistula there in green, and it's coming high up through the internal and the external sphincter. Number 2, 1B, is a posterior horseshoe, which is outside the sphincter complex, so it is in the ischioanal fossa. And 1C is a very hard fistula. It's a suprasphincteric fistula, where it's come above the sphincter complex. And I toyed with the idea of having very simple terms here, but I think we have a self-selecting audience who have lived a life with complex fistulas. They are in what I like to call the 5% club, which is the miserable club to be in, whereby if you're on a chat room or you're speaking to friends who've had a fistula, well, odds are they will be in the 95% success rate club. The patients who have simple fistulas, the patients who have one operation, and for them this is then over. But for those people here, that unfortunately hasn't been true. So let's move forward, and I might tell you about imaging. So this is why I think about imaging. I think about the importance of knowing your playing field, and this is the team from Cool Runnings working out the left and right turns, and it's not too dissimilar to what we ask our fellows and what we do in theatre, which is understanding as much of the information as we can about a fistula. When I see my patients in clinic, sometimes we draw diagrams, sometimes I show them this slide. So if there are any patients that I know, firstly, hi, and thanks for joining. And number 2, apologies for showing you slides you've already seen, but these are the things that our fellows need to note down. We need to know all these bits of detail to try to understand what is a complex problem. Often by the time they've come to St. Mark's or at any other tertiary centre around the UK, they've had lots of surgeries before, so their anatomy is skewed, it is different, it is harder to appreciate and understand. But this is the level of detail we need. This is the level of detail that we consider, and that's what Alex, myself, and Phil, as well as many other surgeons that you probably know, think about. So the role of imaging is firstly to understand, secondly is to talk to you about this picture. So this is what happens when fistulas recur. And if you're in that 5% club, this is what it feels like. I don't have a picture of somebody's bottom where they've done this. This is a patient who has inflammatory bowel disease, but every scar on her tummy tells a story. and it might just tell the story of scars to a room full of surgeons, but to a room full of people, it might tell you, birthdays missed, weekends in hospital, weeks away from their friends and family. And for those in that 5% club, this tells, it tells a lot. And when you see your consultant in clinic, they need to go back to this diagram and they need to say to you, well, look, I've thought about all of these bullet points. And next time we're going to try this, and we're going to try to tackle this little branch and this complexity. For example, one of my favourite things to ask a room full of fistula surgeons is, could you treat this particular tract here in red with a laser? And most people will say, yeah, it looks relatively straight, but of course it's this tiny little 8mm nubbin that you see at the bottom picture over here, which causes the recurrence. This little nubbin also is so high up, it's right at the very top, and it goes to the very front of my PowerPoint here, where this fistula is really, really edging towards the very top of that sphincter complex. So the only way to sometimes access this is a big wide cut, some of those images that Denise showed you before. As I move through, my next slides might have one or two more challenging pictures, so please do feel free to look away. They have all been taken with patient consent. The next picture here describes how many people are taught in medical school about fistulas. And some of these may be words that you've seen in your clinical letters or consultants have spoken to you about. They are way more complicated and way more nuanced. Your intersphincteric fistula is the most common fistula. It occurs, as I said, in 95% of people, and it's fixed with one operation. But you, of course, can have an intersphincteric fistula that encompasses most of your sphincter, and therefore your situation is different. You can have an intersphincteric fistula, and you could have had 2 birth injuries. Therefore, you've already had sphincter damage, and therefore cutting this open and laying it open would not be the right thing. Your transsphincteric fistula will be transsphincteric if it's here in the midst. It will also be transsphincteric if it encompasses, the lowest parts of your muscle here or the highest parts over here. So there are real nuances to understand, and these are how we think about the treatments. But of course, there are lots. So this is the first of those horrible pictures. But here, at each of these points, I hope they serve not as a horrible memory or something that intimidates you, but perhaps something that we might come to understand, thinking about that plasticine model. Here on this top right, you can see the inside lining of that fistula. You can see that glistening area. And you can see that now we've opened it up to the world, and you can see the stitches on the end where we've everted it back on itself. It cannot close over. That is an easier wound over time to manage, and this patient is now fixed. We are simply then dealing with these small fistulas, although numerous, which we have to pick off one by one. And the art of our fistula surgery is to maintain continence and to get rid of all the areas that are in the fistula and around the fistula. And you may hear many of us talk about the concept of rationalization. It's a long, fancy word. We like to say long, fancy words, but it's very simple. We take complex things and make them easier for us to understand. It's a process. It's often a stage management approach with annoyingly time between. And of course, everybody wants things now. They say, look, I have a fistula. You're offering me a stage management approach. Do that over 2 months and I will then carry on with my life. We don't have that luxury because we are waiting for healing to occur. We're waiting to stimulate that healing that we ask to start at the time of our operations. Your surgeons may talk to you about these big wounds, and we think about the buttock fat as wounds that we make holes in, and we may think about this because it doesn't involve your muscles, it doesn't involve or alter your continence. If it is higher up, often we get these patients referred to us at St Mark's where it's more challenging to treat. We think about more interesting and nuanced ways, and here I credit my mentor Phil Tozer, who's on the call, for kind of training lots of us up and teaching us how to do this, but that is draining inside the rectum. Horseshoes are always very challenging. They depend on where they are in terms of which structures they're between, but also how high up you go to. And the treatments will flash on the screen, but just to understand, I think for the first time, what do people mean by a horseshoe? They mean a tract that doesn't go in a straight line, but it goes genuinely in a horseshoe. And of course, they can be a near complete donut, They can be half a donut or a small U. So this is again, I don't have any pictures of fistulas and bottoms, but it's a slide I teach junior registrars on about shared decision making, because this is the situation we're in. It's a very hard job to be a fistula surgeon, especially a tertiary fistula surgeon, because we could choose other aspects of colorectal disease to think about. So cancer patients more or less have 100% success rate. If you have an early cancer, you can take it out. And of course, there are the more complicated recurrent cases, and those are not amenable. But in general, when I'm training trainees to say, hey, what do you want to choose? You could pick path A, which is slightly more easy for you to consider, or this difficult path where some of our success rates are 50%. And that means some of our failure rates are 50%. And the people that we get to know through our clinical consultations will come to us and say, look, it's not worked again. And you will feel that concern as to, right, I need to now go back to basis and work out what the next step is. And therefore we use adjuncts, diagrams, patient information leaflets. We have the support from our colleagues. I mean, you've met Sister Denise for the first time today, many of you. She's fantastic. We couldn't do what we do at St Mark's, Phil or I, if we didn't have a Sister Denise. But I think more importantly, I might put the Fistula Awareness Group here. The peer-to-peer support that you give each other is incredible. It's a lived experience that neither of us know or have. We cannot teach you the ways of what it looks like, or what clothes to buy, or how do you manage to wear a beige linen suit, which somebody asked me once if I have a fistula. I don't know how to do those things, but I can point you to the people who have lived this experience and who can tell you. The other thing I think we're always aware of, and this is Asmina Verji, who is a patient who has posted her experience on social media. She's talked about her journey. She's talked about different surgeries that she would have accepted at different moments in her life, and I think we recognise that recurrent disease means a kind of an agile approach to thoughts, to considerations, and to treatments. And I think some of her story that you may find on social media is incredibly inspiring. She's a wonderful person, and it really is a great kind of way of considering how decision making doesn't have to be correct from the start. You can change your mind at any moment. We decide on this basis, morphology, what it looks like with the MRI scan, if you have Crohn's disease, how many operations your local team can do, what type of surgeries they can do, how your previous surgeries have left the perianum, is it scarred, is that going to influence our next operations, and really what the patient wants to do. Every time I show this slide to patients, it's inspiring, but also not so much. If you know that there are that many options to treat something, well, that means that there are no front runners. There is no operation here that gives you a 100% success rate, but we are innovating, we are thinking, and I'll show you some of those shortly. This is another way I perhaps think it's maybe useful to some of the more kind of experienced patients who've lived with the more complex fistula treatments that they've gone through, but there are different ways of grouping these together. Setons and laying things open. We like to lay things open often because it gives us a good success rate. We can cut a fistula away and it's over, and we tend to have a number in our mind of how much muscle there is above. And I often say to patients, and again, forgive me if I've said this to you, but if you are holding an object in your hand and I take away, and you're holding it with 1, 2, 3, 4 fingers, and I take away one of them, well, hey, look, I still can't take it from your hand. I think setons are something that buy people time. I think there are some things that bridge between surgeries, and in many cases, some patients choose to say, I need a break. I need 2 years. I need to complete my university degree. I cannot and do not want to keep coming to your hospital, having scans. I just need some headspace. And the sphincter saving procedures, many of which I listed beforehand, which involve no cutting of the muscle, need again your surgeon to start thinking about these various factors. I've included some of the operations that I think are quite good, specifically because they have another reason. So FILAG has up to a 57% success rate, but you can repeat it. And the reoperation rate here in the big meta-analysis, which is where we group all the studies around the world that have been done, was just over a third. And therefore, even though it feels like it hasn't worked the first time, there is always the second time, and there is always maybe the third time if you choose to consider it. At St Mark's, we are always looking at newer modalities. We are always conscious that the drug company will give us higher rates of healing at the start, and when we actually put it into practice, this isn't often true, but we're thinking about things like Obsidian, which is a platelet-rich bioactive matrix, which basically means we take some blood from you, we spin it around and inject some of the platelets in, which can show some benefit in healing. And most recently, this is a picture of Phil Tozer. We have started with the help of a surgeon from Denmark to learn this process of using adipose, which is fatty tissue, derived stem cells from here, the patient's abdomen. And, I think as a unit of fistula surgeons, we are conscious of the fact that because we are often deemed as one of the big centres for fistulas, it doesn't mean that we hold our hands up and say, we will learn no more techniques. We are open to it. We invite other surgeons from around the world to show us new things that they think are good. We then take this on ourselves. We academically appraise it. We can offer this to some of our patients. This is a cool slide. I'm one of the robotic leads at St Mark's, so forgive me, it's got this thought about it. But I think as well as innovating in terms of devices, we also like to innovate in terms of thought process. So this is an artificial intelligence program that looks at your bunch of random Lego and gives you an idea of the various things you can make. And then we try to use this as a step-to-step guide to plan people's operations. This is something that we're in kind of early phases of. We are trying to democratize our radiologists, our surgeons, our fistula knowledge here at St Mark's that we've learned over years. And there are ways that perhaps this may be able to disseminate into the rest of the NHS. So that's a project that we are in very early phases of, but I hope that might be beneficial over the next few years. So my conclusion is we like to work with our patients in a team. The patient is part of our team. We are aware of agile management. Often with recurrent and difficult conditions, we have to be agile and we have to, understand what failure is and what success rates are. 3 options are always laying things open, any of the sphincter-saving procedures in the CETON, and we quote 50% success rates. So we have to work out off that cocktail menu which one is the right one for you. And thank you very much for listening, and I'm sorry if I run over.
Fantastic. Thanks so much, Katz, for sharing that, which was, I'm sure everyone will find very, very useful. Now, Katz mentioned the art of fistula surgery is maintaining continence, so that leads us on very nicely to Alex Leo, who is a consultant colorectal and pelvic floor surgeon, who's going to be talking about exactly that, fistula surgeries and maintaining continence. Alex, if you can hear us.
You can hear me?
I'll pass it on to you. Yeah, we can. Thanks, Alex.
Fantastic. Thanks for inviting Sal, first of all. Thank you for the Fistula Awareness group. I think it's absolutely fantastic idea to group all the patients together to have such a discussion, even though I appreciate that sometimes might not be easy to talk about this topic. But as Cap said, I mean, most of you unfortunately are part of the 5% club, so already been through quite a lot. And I think this is a very nice opportunity to explore things around. You gave me a very nice presentation topic in terms, as you know, I've been spending many years on dealing and treating patients mainly with fecal incontinence as well as complex benign proctology. And for those who know me, I'm a very, very fond of quality of life as well as everything around. So what we are talking here, I will sort of step back a little bit from the fistula itself and talking for a few slides around the incontinence and the continence. What does it mean? What's the meaning, and why it might be so important for us? Because that's the principle. We have a very, very big challenge here, and I'm sure my colleagues here will agree with that. And the challenge here is that the eating counts a lot for us as well as our function. Okay, so the difficulty that we really have, all of us, is trying to find a way to give you a fistula heal at the same time maintaining your function. So the challenge are even more challenging, more difficult. So we really face something extremely hard here on a daily basis. I know you already had a very similar slide with Phil told the last time, and Caps went through a little bit of anatomy as well. The reason why I put this back is because if we want to understand better the function, the continence, and how to preserve that, we really need to refresh ourselves a little bit on what we are looking at. So it's not obviously my intention or my meaning to give you a lesson on anatomy, absolutely not, don't take it that way, but just to understand better what we are looking at when we are talking about the anus, so the back passage, because that's the place where the fistula runs, right? So what I'm going to show you here is a sort of, it is the back passage, so the anus seen by the front, so imagine to cut the back passage in two, and we're looking at the front of it. And I'm not going to go through all the details, as I said, but just two main structure I want you to have in mind, which somehow Mr. Sahnan showed you on those complex fistula tracts as well. So now you can put all together and hopefully have even a better idea what we're trying to explain. So the inner muscle that you see there is a sort of a tiny fibers that goes all the way down there. That's what we call the internal sphincter, okay? And the reason, and what I'm trying to do today differently from Mr. Tozer last time, if you had a chance to watch the video or to attend this webinar last time, is giving you the idea not much of the anatomy of the muscle, but more the functionality of the muscle, because the physiology of the muscle, that's what it counts the most now. So that internal sphincter is what gives us for 80-85% our continence, okay? So it's deputy for 80-85% of our continence. It's constantly there, so you have a constantly pressure. Even now that I'm talking to you, even now that you're listening to me, that muscle is at a constant level of pressure. And it's extremely important because if you do not have that, obviously you might have accidents or be not able to keep your stools inside your rectum. As you can see, there is an outer ring, which is the external sphincter that Mr. Sahnan was talking about and mentioning about it. And that external sphincter is what we call the voluntary muscle. So it's basically that muscle that we decide when is the time to contract, to squeeze. Okay, let's say that, for example, now I have a stimuli, I have a need to go to the toilet, but because I'm giving you a presentation now, I can't go there. So what I really do is just tell my brain, tell down there to keep it squeezed on a way that I do not have any accidents. And the magic way it works is I give a signal to my brain, the brain gives a signal back to the muscles, contract those, and avoid to have any accidents. So I really keep in a very, very easy and understandable words, but as we understand, you're all patients here, you're not medicals, so I'd rather prefer to use very common, easy words and have a better understanding each other what we are talking here. So important are those muscles because obviously they are the deputy for the continence here. So those muscles here, all together, they work to give to make us continent. Without those, we will lose our rectum content. Now, to give you a better idea of how incontinence works, now you might smile at that, but I took this example from Professor Phillips, who was one of my masters, and he taught me a lot about inner fistula and physiology and continence. We try to understand better how the rectum works when we try to keep the stools there and when we need to go to the toilet to open our bowels and to pass stools. So this is a Mayer bottle, just put it upside down. And what happens is, let's say that now you need to go to the toilet. We open the lid. Let's say that opening the lid means metaphorically to put our pants down and sit on the toilet. And you have the tip of the bottle there, which are our sphincter muscles. And where the hands is on the main body of the bottle is the rectum. So what happens if you keep the mayo upside down? The mayo, you can try that, it won't come up because you got the sphincter muscle, you got the top of the bottle, which will keep the mayo inside the bottle. So in order that to work, you will need really to have the sphincter relax, so that the top of the bottle, to opening up, and you need the rectum to squeeze. So the squeeze, you apply squeeze on the bottle, so on the rectum, and the stools, the bowel content will come out. Okay. What happens if I have a damage on those sphincter muscle? What happens if I have a damage at the tip of the bottle? That's what will happen. Instead of having a pressure applied in order to go to the toilet, anything will come straight forward outside. Okay, and that's exactly what happens when we have an issue, because we might have damage the sphincter muscles. That's why it's very, very important to be careful and to choose the right option when we're talking about a fistula. Now, what is fecal incontinence? Because it seems a complex word here, but fecal incontinence is not just a leakage of stools. What we see there is the tip of the iceberg. It's just not leakage or having gas control, but it's much more. Okay, there is a lot that patients unfortunately hold on altogether. We are talking about embarrassment, we are talking about anxiety, we are talking about the fear of those patients to go around or to go out either for shopping or to have a dinner because they need a toilet. They need to map their life based on where the facilities are. So in extremely, extremely hard life. So it just is what we see, what we talk about incontinence, which might be that leakage at the top. Underneath, the iceberg is much, much bigger. Those patients, unfortunately, have an incredible hard life, and it really might affect their quality of life in a very, very significant way. And that's why it's important that we do not just look at that tip of the iceberg, but we look at the overall picture and we try to help those patients. Talking about incontinence in general, and I'm not talking about incontinence for patients who has fistula or who is planning to have fistula. The incontinence is much more common than we think and believe, okay? If you're talking about numbers, if you look at the literature, we're talking about 10 to 15% prevalence. But there are some papers that are telling us that because patients are ashamed to claim that incontinence, they are worried to go to their GP and talking about such problems that they have because of the intimacy, because of the problem itself. Those numbers could be much, much higher. But even if we talk about that 10, 15%, that means that every time that you go outside there and you look at 10 people, there is a very good chance that at least one of those 10 people, if not even more, has some sort of incontinence symptoms. So it's much more common than we all believe. Now, this is very similar to Mrs. Sahnan presentation, and I'm not going to go through the classification, the part classification of the fistula, but just to, again, to refresh the fact that the fistula might be as simple as he was saying, and when they are simple, obviously, we are all happy because the patients are happy, surgeons are happy, it's a happy life because they're easy to treat, and there is a very, very, very high chance that we might not only deal with the fistula in an easy way, but we can treat the fistula and gives the success that we both want. But unfortunately, there are also those complex fistula that they might rise further up in the sphincter complex muscle. They might give secondary branches and they behave in a much more complicated way. And when that happens, obviously, when the sphincters is more involved, the difficulties and the challenges increases a lot to find the right option that can cure the fistula and at the same time preserve the continence for those patients. Obviously, the more muscles are involved, the more difficulties are, the more challenging are for us and for the patient itself. And obviously that percentage of success, they might diminish in a significant way. Sorry if I go back there. What I was trying to say is that not only the percentage, obviously the muscle counts there, for looking at the continence, but we need to look at the overall pictures because our patient comes to us, but the variables are so many. Someone before was mentioning about patient who might have more children, who might have already the sphincter damage because they might have had an oasis or the sphincter trauma during the delivery. The age counts a lot because obviously the muscle with the age doesn't function as well as a very young, strong man or a woman. Perhaps patients had a previous anorectal surgery, perhaps had hemorrhoid surgery and the sphincters that were already partially damaged. So the variables to those sphincter muscles is incredibly high. And we need to look at the overall picture. I cannot consider a sphincter muscle the same for everybody. If I take two people the same age, same gender, and they come to me, their sphincter function could be completely different between them. So it's very important to count the overall picture and to look at that in 360 degrees. I'm going to give you a couple of pictures of ultrasound scans. I know it might look a completely a black and white picture, because it is. But for those who had experience before, this is basically an endo-anal ultrasound scan. So it's sort of a jelly scan for a jelly scan that we do for bellies, but we do it down the back passage. The black hole you see in the middle is the probe. You see a couple of circles around, which are obviously the condoms, the lubricant that we use. But what I want to show you there, if you look, there is a sort of a moon shape, whitish color, and that's the puborectalis muscle that sits at the top. But when we look more at the meat or the anal canal, you can see the sort of a blackish circle. That's your internal sphincter, how it looks on an ultrasound scan. Now, all the others will agree with me, this is not the gold standard to assessing fistula. Absolutely, I'm not saying that. But when we look at patient with complex fistula and we need to take tough decisions of whether to lay those fistula on, we are adding this sort of imaging, not much to look at the anatomy of the fistula again, which is assessed by with an MRI and completely different kind of scans. But this kind of scan or ultrasound scan help us to understand how the muscles are. Okay, so we'll focus mainly on the sphincters. We'll try to understand the thickness of the sphincter muscle, to understand whether those muscles could be strong enough to be laid open or not. Okay, that's what we're trying to look here. And we can see even lower down, this is the lower part where you see the grayish elliptic shape that's all the external sphincter. Obviously, you could see the fistula as well there, but we're trying to understand better here is whether those muscles are strong or not, because they might have, again, as I was saying, because of the many variables, you might have a patient, for example, mentioning before, who had a previous anorectal surgery. It happened to me to have seen a patient who had a 2-3 hemorrhoidal surgery, and unfortunately, during the hemorrhoidectomy, they damaged partially the internal sphincter. And when you go back there, you might see the internal sphincter damaged in several parts. So already know that internal sphincter is not going to hold on if I also add a lay open on top. So that's what it might help me to take a decision of what to do as a next step. Okay. Now there is another test for which I worked hard over the years. And this is a test that checks for your anorectal function, basically. This is really tell us whether your function overall is really good or not. And again, because of the variables I told you before, that function might vary significantly between patients. This is an example. This looks like an ECG, basically, just a trace, and where you can measure that resting pressure. I was telling you whether you have a constant pressure down the back passage. You ask the patient to squeeze, in that red square box, you see the increment of that squeeze and so on. I'm not going to go into the complexity of that, but just to give you an idea of how we can measure how your function, how your muscle function down there, right? If you look at these other one, for example, you see what the difference there is between a very, very good pressure up there and I go there, and you do not really need to have a medical background to see that here there is no function at all. This is a patient who has incontinence for other reasons, but the pressures are very low. So it's a markedly difference here, and I brought this up just to show you how different could look. So I usually, if I need to take together with the patient the tough decision to go ahead with the lay open, when I know that it's a complex fistula behind, we usually look at anatomy. We look at anatomy of the fistula with an MRI. We look at the anatomy of the sphincter with an endo-anal ultrasound scan, and we look at the function of those muscles with the anorectal manometry. Again, the idea here is try to understand better the function of that patient. We are all different, as I was saying before. If I take the same age, same gender patient, we might see completely two different function there. So if I need to, we used to say, and Mr. Sahnan will agree with that and told it as well, we used to say that initially surgeons were looking how much we were cutting down there. Then we step over and we look how much we were leaving of the muscles there when we were cutting. My idea is slightly different. So we I'm not really looking how much I cut or how much I leave, but I need to look how the function is before deciding how much I can cut. Because if I cut 50% in the patient where the function is already poor as a baseline, I'm going to make a drama. I'm going to make that patient incontinent for sure. But if I cut 50% in the patient where the muscle is extremely strong and high, that incontinence might not come at all, or anyway, it might be something that we can overstep and carry on anyway without the major drama. So it's very important the baseline here when we take a decision on what to do. Again, is delicate balance, okay? We have surgery, but at the same time, we want to heal the fistula. The patient wants the fistula away. We want, as a surgeon, the fistula to go, but at the same time, we need to preserve the function of that that patient. So again, very, very difficult decision. Depends really from the classification of the fistula, whether those are superficial, more complex, and so on. But I think Mr. Sahnan went through very well here. So I just take home message here. There is an individualized care. That's the way I like it. All patients are different, and we need to put all things together. We need to put the imaging, the function. What are your goals as a patient? What you're trying to achieve? As Mrs. Sahnan was saying very correctly, some patients that sometimes they are at a time where they need to put everything in a hold, breathe, go away, and come back perhaps in a couple of years' times. So it's all a matter of patient goals. This is a patient-centered, tailored treatment. We want to preserve the continence, but at the same time, we need to run through the several options, and we take a decision together. I don't think it's a patient decision or a surgeon decision. It's a decision that we really take together there. That's it for me, Sal.
Fantastic. Thank you so much, Alex, for sharing that, and with your expertise in the pelvic floor area. I think everyone will agree we found that very, very useful. I forgot to give Caps a round of applause as well, so we'll do a joint round of applause for Caps and Alex, everybody. I know we can't see you, but thank you so much. A huge thank you on behalf of the Fistula Awareness Group, and I'm sure the patients that are attending today, for you taking the time to come and present. You know, this is quite a difficult journey, and these sort of educational pieces that we put together with the Fistula Awareness Group, and getting some of the best and the greatest colorectal surgeons or surgeons in this area to come and talk to us is very, very useful and very greatly appreciated. So thank you very much for your time and sharing all your knowledge with us. Now we will, I think Kat's mentioned about Fistula Awareness Group and living with fistulas, is as much as it is a you know, medical element, and you know that we've got some great surgeons in the UK, but it's also about people sharing their lived experiences, and as part of that, sorry, I did mention in the program earlier, but we like to share patient perspectives. So I will now, I think we're running okay for time, so I'll keep it quite short, but for the next few minutes, we'll talk about my patient perspective. So my name is Sal, and I am a fistula patient. Unfortunately, I was part of the 5% club that Caps mentioned, probably worse than being a Arsenal supporter with what happened last week. Definitely not a club I would have signed up to, but unfortunately, that's what life took me to. I am in my 30s, and hopefully I'll be able to share my journey with you to give you a sense of, you know, belonging, that you're not isolated, because this condition can be very, very isolating. So just a bit of background on me. I'm in my 30s, and pre-joining this 5% club, I was a very socially active, loved traveling, going out and about. And sometimes I sort of used to wonder how I kept up with life myself. And then 3 years ago, I developed a buttock boil, and had no idea what it was. And I Googled it, and Google said all sorts of weird and wonderful things. So I waited and watched, and then went to my GP, and it started becoming slightly symptomatic. I again had no idea what a fistula was. Like many of the other patients here, you will not know what fistula is. You know, if you talk about other diseases in the world, like cancer or heart diseases, you may be a little bit more aware of it because there's a lot more awareness around it. I had no idea what a fistula was, and I didn't know what was going on in my bottom, where this bump came from, and it was absolutely non-painful. And as many people do, you go to your GP, and the GP looked at it and, gave me a few antibiotics here or there, and it was just a wait and watch because it was not symptomatic. Then it started becoming symptomatic, and that's when one of the GPs thought that it could be a fistula. And they said fistula. I said, what is a fistula? I have absolutely no idea. And that's when, again, I did the mistake of Googling and thought, oh my goodness, do I have this fistula? Um, Anyways, then long story short, I then lived with a fistula actually, that was absolutely non-symptomatic. So initially, when I had a fistula and was diagnosed with a fistula, I lived almost 7 months without any form of repair attempt or any surgery. I had what the medical world would say a complex perianal transsphincteric fistula. Again, I really didn't know what that meant. Didn't know what sphincters were either. But I was hopeful that I was in the right hands with the surgical team. And given that all this time I had no sort of symptoms, I thought, well, hopefully this will just go away. Needless to say, I know 3 years later, that is not what happened, unfortunately. And a lot of patients talk about their journey, and it is a roller coaster journey. And I think some of the surgeons mentioned about this being a team of decisions. And, through my journey, that's really important. There were parts where I was non-symptomatic, but I did want to do certain things. So, with some of my surgeons, we said, let's put things on hold. So, it is very much a team decision. Your surgeons have obviously the medical expertise. They spend years studying medicine. They spend years training and then becoming consultants. So they've got the tools. They know what to do. But as part of that decision making of what needs to be done, it is very much a patient and surgeon team decision making. So anyways, I then, I had no idea what a fistula was, had no problems. And I'll show you some pictures just to show people, how you can have a fistula and sometimes it can be fine. And for me, it's more prevalent because my sort of down part of the roller coaster started after I had my first surgical attempt. So I'm going to try to share. I can. Here we go. So this is me, living, no, this is me. This is me living my life, with my complex transsphincteric fistula, non-symptomatic, no problem at all, waiting for my surgery to happen, with under the NHS. And you can see there I was traveling, I was doing all sorts of things, living my life, going out hiking. I love traveling, and I still managed to do that with a fistula, not knowing what roller coaster journey I was going to get into. I then had my first surgical repair attempt 2 years ago, almost this time 2 years ago, and we opted for a laser option. And again, the reason why I'm sharing this is, I knew as much as I could know from my surgical team. Going through the roller coaster journey, I learned a lot more in terms of, all the different options and went into it. When you meet your surgeon, they will try to give you all the information, but there's only so much you can absorb. So, these sort of support groups and doing your own research is also quite important in helping you make that decision. I then had my first, so like I said, I had my first repair attempt. I didn't even know it was a repair attempt. I just thought we were going to get rid of this fistula that I have. That's not causing me any problems really, but had a bit of drainage here or there. unfortunately, that's when things went downhill for me personally in my journey. Following that, I then developed abscesses, and my fistulas decided to grow twins, and grow into lots of different sort of, extensions, etc. And that's where, my real down battle with my fistula journey started. And as much as and I had the down battle for almost a year figuring out what we're going to do. Because I think one of the things that Phil mentioned in the previous webinar is your fistula will end up where it needs to end up. You can try to you can try to do as much as you can, but it will end up where it needs to end up. And patience is a virtue. That's one of the things that I've learned. And so it just has to take its time and do what it needs to do. And that downhill battle that I had, where everything was going wrong, and things were coming out of my bum that shouldn't have been coming out, um, was the most challenging part. So not only was it physically challenging, but mentally challenging. So, if you are experiencing this condition being not just physically challenging, but also mentally challenging, that is normal. You will go through the mental process, and it's all sorts of mental process, because, you're worried about what are you going to do with work? How are you going to go out and about and meet your friends and your family? There is such a thing called compassion fatigue. I am very fortunate to have friends and family around me, but every time I had multiple surgeries and multiple setbacks, and sometimes I would have recovery periods where it would be absolutely fine, and I thought, wow, great, this is over. Um, and then you're going back to surgery, and a lot of your friends and family, they'll be there supportive as much as they can, but they get compassion fatigue as well, as much as you as a fistula patient. Um, want this over. It's very hard for family and friends to be compassionate with you throughout this whole journey. And that in itself can be quite isolating. And I found that quite challenging, because, I'm very lucky to have family and friends, but then I realized that, there is compassion fatigue, and there's only so much they can be there, which is why, again, these sort of support groups where you have other patients who are going through this. I've made loads of friends out of this as well, and you can actually almost be more empathetic with each other than your friends and family can be with you. So yeah, downhill battle. And I'll show you some pictures. Some of these may be a bit graphic, so if you are squeamish, look away. You will see a bit of my bottom with chunks cut out as well, and I'm very happy to share that because I've consented. But this is when I was going through my downhill battle. Um, So, gauzes and swabs become, crazy. You have loads of bleeding. At one point, I had two setons with two external openings. There's me in a hospital crying because I've just been told I have an abscess and I need to go in for incision and drainage. And there's a picture of me in hospital again, potentially getting a bit of sepsis, all that sort of drainage and stuff. So it is it is challenging, and you do see things that you don't expect to see. um so bear with, keep going. There's a saying that Winston Churchill said, that when you're going through a hell, keep going through that journey, if you are going through that down period. um and then I'll probably have another minute and I'll end. So on a slightly higher note, so where I am now, I had loads of sort of different attempts that didn't work, abscesses, incision and drainages. And unfortunately, your hospital will become your best friend. I was used to going Friday nights out partying in Soho, whereas I then, ended up spending Friday nights in the hospital. So it can be difficult, and you see it's people on social media, people going out where, and instead of you being with your friends and family, you're actually sitting in a hospital not knowing what's happening. You might potentially have sepsis. Um, so to end on a slightly more positive and upbeat note, where I am now, so I went through the whole stage post process, what Kaps mentioned about rationalization, and even then there was a few failed attempts. So there's only, if you've got really good surgeons and you're confident and you trust your surgeon, they're only as good as they can be. This condition unfortunately does have a mind of its own. And you will have multiple failed repair attempts, and your plans will change. And I think that's what I realized. One of the other things I learned is, in the beginning, I had a certain plan, and that plan evolves, and you discuss that with your surgeon. So yeah, on a more positive, brighter note, where I am now, I think I may be fistula free. So my most latest op was 5 months ago, which was a lay open or a fistulotomy. And that is obviously, like Cap said, considered, and Phil said in the previous webinar, considered probably to be the most excellent outcome. And luckily I was able to have that. And I was under the care of a very, very good surgeon where, continence was very important to me. And I think other patients will realize, continence is very important. And also not just continence. I think a lot of, in the medical world, continence is, or incontinence is referred to when you're, just not able to control your bowels at all. But for me, what was really important wasn't just that extreme level of incontinence, but, I'm a young man with a, future ahead of me. I also didn't want to have minor incontinence as well. And I think that's where I was able to have very good and open dialogue with my surgeon, and was able to, portray to them. I think the other tip I would give is, really tell your surgeons where you're at, what you're thinking, how you're feeling, so that will help them in terms of giving you advice on what to do. So I, like I said, was lucky enough to have a lay open of the part of the track that was going through the transplanteric part. It was low enough. We made a decision together that actually we will take that risk of even minor incontinence. And also from a surgical perspective, they thought that actually, on a risk-based approach, there's, they've done everything they can to ensure that there is minimal minor incontinence off there. So we went for that, and that's where I am now. And I thought that after I will have the lay open, that things will be all hunky dory. To a month later, I'll be running around. Now, unfortunately, the reality is your bum bum, I call it my bum bum, will never be the same as your baby bum bum. There's all sorts of things involved, and that's something you can discuss with your surgeon. But just touch lightly, scarring is one thing, and just your sort of pelvic floor muscles getting used to post operation. Fistula surgery, any kind of surgery in that area is very assaultive. It's very traumatic for your down there. So it is a very long journey, even though I was very pleased that I had the best excellent outcome. It can, the recovery after that can be very challenging. And I have times in these 5 months, I've been able to do a lot of things that I probably wouldn't have been able to do. I was in a much better position where I was last year. And there is pain sometimes, and there are times where I can't do things, but I am slowly getting my life back. So for anyone who thinks there's no light at the end of the tunnel, there is light at the end of the tunnel. And what you think success is in the beginning, because my view of success was, want to get rid of this fistula, and actually once the surgery is done, a month of recovery, and I'll be fit as a fiddle and getting on with life as before. That sort of success has changed, because as I've learned and I've got to hear other people's stories as well, and the discussions I've had with my surgeons, the reality is your bum may not, if you are in that 5% club, things will be a bit different, and you just learn to embrace those. So hopefully, I didn't want it to be a sub story, and I didn't also want to just over glamorize and be over positive. There are parts where through this journey you will have downs, you will have mental challenges, and physical challenges, and that's normal as well. And you're not alone. A lot of other people who have these stories will share that with you, and that's why the sort of the peer group and the community element within fistula awareness is really important, and because other people who've gone through it can empathize rather than just sympathize with you. The final thing I will say, a lot of people, say that there's no success stories. The most the 5% group, you hear about those more. The 95% group of the people who, have had simple fistulas, all been bish bash bosh, you don't really hear a lot of that, because a lot of people want to get over their bum drama and just get on with their life. And great if they're able to do that. And so you do, by virtue of just the fact of, the recurrence element in this, hear more of the negative stories. But, there are lots of success stories, and also what you think is success will evolve over time. So I think I might have gone over a little bit. I can waffle, but I hope the patients, I hope if you are going through this journey, you know that you're not alone. There's lots of resources and support out there. Really have open dialogues with your surgeons, all your surgeons. I will say one thing, make sure you've got a good colorectal surgeon. If you've got a heart issue, you would not go to an orthopedic surgeon to give you a heart bypass. So having a good colorectal surgeon is really important. From my experience, I've been lucky to have that. And also, when you see your surgeons, don't just talk about the medical element. Really let your surgeon know your personal element, because that also helps them come up with a surgical plan. So yeah, there is light at the end of the tunnel, with no pun intended. And if you are going through this, I empathize with you, and there is a community out there that does. And do reach out to the Fistula Awareness Group for that sort of community support if you need it. Right, fantastic. God, that's my story. I could talk a lot, but it's very hard to talk about myself. So I hope you all found that useful. Great. Also, so now I'll get back into my member of my Fistula Awareness Steering Group hat. And I will say a huge thank you to all the other members of the Fistula Awareness Steering Group who've helped make these webinars and these webinar series happen. So that's Gillian, Rebecca, and Laura as well, and also Phil Tozer, who's our clinician lead, who does some wonderful stuff in the world of fistula and is a real supporter of the Fistula Awareness Group. So now the much awaited Q&A. So Phil Tozer, renowned colorectal surgeon, who doesn't need much of an introduction, as I mentioned before as well, will moderate the Q&A. Phil, are you?
Yeah, ready to go. So we don't have a lot of time, so I'm going to ask each of the different panelists to give a really rapid answer to questions. Denise, the first couple are for you. There are questions about pain, 2 or 3 questions about pain and about opiates for pain. Can you just give us your headlines about managing pain again?
Managing pain during the first, definitely for the 7 to 14 days post-surgery, you're going to need sort of regular, stronger paracetamol, stronger than paracetamol. This can be cocodamol, sometimes it's tramadol, sometimes it's Oromorph, but if you're having these drugs for pain relief, you also have to take laxatives. And that is the big take home from here, is if you're on anything stronger than 2 paracetamol, take some lactulose or some Laxido. It doesn't mean that you can't have the opiates or the Oromorph or whatever. It just means that you just have to be a little bit more bowel aware, because we don't want you straining during this first sort of couple of weeks.
And non-steroidals, if you don't have IBD, can be added in as well. Are you happy with that, Denise?
Yeah. Sorry,
Yeah.
I was burping.
Okay. The next question is about the sort of absence of digitation from many places. Sal introduced you as a specialist fistula nurse. You are in fact the specialist fistula nurse. There isn't any other in the UK as far as any of us knows, and so digitation is making its way around the country to other places, but hasn't made it everywhere yet. But you're working on that.
I am working on it. We're working on it with our cohort of patients. We're seeing over 30 patients a week in the fistula clinics. So, if we're giving that information to 30 patients that are from Kent, Cornwall, north of Watford, they will be then spreading it to their practice nurses as well. GPs are a little less receptive to digitation and change. but I'll get there.
You just made everyone from the north feel abandoned. But
Sorry.
no, that's okay. And then finally for you, Denise, could you just explain a little bit about using soap, using a bar of soap for digitation?
So some people can't physically touch their wound. They just can't go near it. They won't go near it or whatever. And for some of these wounds, especially the sort of the larger wounds where they've got tracks that are quite easy to digitate and easy to put your finger down and run it down a sort of like you've got an island of, tissue, and then you've got your fistula around that island, and you just have to rub your finger around it. Some people can't do that. So using the corner of a bar of soap while you're in the shower to rub it round sort of the ring road, really, that you can actually put more pressure on it using your bar of soap than you would be if you were using your finger, if you're a bit gingery at touching it. So that's why we use the bar of soap method. Just get a way of getting your fistula being touched, really.
And for anyone under 25, just ask your parents what a bar of soap is. Okay, Alex, some questions for you.
Yes.
Why am I told I need packing if it could potentially cause further issues?
Packing.
Yeah.
Well, all right. It's a word that personally I'm a little bit dislike, put it that way. I'm not a person who likes packing, mainly because it causes a lot of pain. I can't see the benefits out of it. So I rather prefer not packing it, to be honest. Not sure whether you other experience it there, but there is a nice trial as well that we can mention here today for you. But it's demonstrated that basically it just causes pain and doesn't cause any really advantage to the patient. So I'm not really for packing, just to cut the story short.
Very good. And not everyone has caught up with that principle around the country yet, have they? But I'm sure that everybody will.
It's similar to the digitation for cysts that needs to go
exactly.
around the country, including the north.
What do you think about? We're not trying to be mean to people in the north. Okay. What about the colour of discharge, Alex? Do you worry about the colour of discharge from a fistula before or after repair and what that means, or is it not something that you pay much attention to?
No, I mean I do. If I see this very, very purulent color of the past, the greenish, brownish, smelling more than anything else color, yes, I would be particularly more worried of an underlying abscess if you're talking about preoperative assessment. So perhaps having a proper MRI and assess nicely the fistula before doing the surgery, I think, is absolutely pivotal. Afterwards, again, it might be a sign of infection, so it's really good to see what kind of discharge is. So when I have a patient in clinic for a follow-up, if he's dubious, has some doubts about the discharge, I like to see it myself to see how it might look and see whether that might be a sign of infection of another abscess coming or whatever. So I'd rather to see that, yes.
Thank you. What do you do with skin tags that are formed after surgery?
Well, it's the latest the problems in terms of you need to look after the fistula in first instance. Let's say that fistula is fully healed and everything is nice and successful as we wish from both sides. Then obviously a patient still having skin tags and there's causes issues or problems in terms, it might get inflamed, irritated, grabbing around the cheeks or whatever, then we might feel to get them off without major issues. Can be done either under local light sedation or even general anesthesia sometimes. So yes, I can't see anything against that, unless they're very minimal skin tags that I would be very, very cautious to take them off, because sometimes it's more the pain that you might cause afterwards, postoperatively delaying wound healings and so on, rather than benefits really.
Yeah, and if you are going to do it, you'll wait right till the end, right?
Yeah,
Absolutely.
that's what
you were saying. Wait till everything.
They're really the end.
Yeah. Okay, and the final question for you, Alex, there's a couple of questions about things that people can do for themselves to help with their continence impairment, exercises they can do, and anything other than exercises they can do.
Exercise we are talking about, I guess, general exercise, or we're talking about pelvic floor exercises,
I
which
think
is slightly
probably they
different.
mean pelvic floor exercises.
Yeah, so pelvic floor exercise is something that, yes, definitely helps either prior and post-operatively, helps to strengthen the muscles. There are a lot of YouTube's video. If you don't have a local colorectal physiotherapist who could look after you, so there is a lot of things that you could do in order to strengthen the muscle in that sense. Rather than that, for your muscle, very important, if you like it, you could do yoga, Pilates, helps a lot. So it's something that is out to the pelvic floor, but somehow helps the pelvic floor. So it is something that is absolutely nice to advise for patients. So if I have a patient who comes back to me and say, "Oh, I do Pilates," I'm very, very keen for it and go for it. Helps in many ways.
Brilliant. Thank you, Alex. Caps, what might it mean if you've got little pinpricks near the external opening, either after a repair has taken place or if you've got a seton in place? What can be done about that?
Yeah, so we're creating tunnels which we are bringing closer to the bullseye of the anus, and the bullseye is that middle bit. Often we create the hole, but if there are additional pockets of infection which are not draining through that hole, they need to be opened up and drained. The other thing that we sometimes think about if we see lots of tiny little holes is there an additional component such as hidradenitis suppurativa, which can exist as its own condition. It can exist in conjunction with fistulas as well. So it's always mindful. We get, again, a number of patients who are referred for fistulas to us, but actually they don't have a fistula, i.e. a connection to the skin and the gut. They have this other condition, which is a connection between skin and skin, and that's managed differently.
Thanks very much. Can you explain why some patients might leak a little stuff that looks like stool through the external fistula soon after a repair, like an advancement flap, for example? Does that definitely mean that the repair has failed?
No, and I it's a very hard concept. You know, you go through so much physically as well as psychologically to go through these repairs. You are you're conscious of almost anything that happens in your bottom that's not normal. I think we perhaps do a bad job of explaining what early success, late success, and sustained success is. If you have some discharge, that does not mean things have failed. You can have a later success rate. When we are putting the fistula back together or removing it, we are stimulated healing. It isn't like Star Trek. You know, I say that lots with laser surgery. It isn't that we move this laser and everything just seals up beautifully. We are allowing the body to heal itself. So a little bit of discharge that one gets immediately afterwards does not mean everything has gone wrong. It means pause, wait, things may turn good.
Thank you. What's the success rate of lay open of a primarily intersphincteric fistula in a woman after a traumatic birth? And would you worry about lay open in that context? And what other options are there?
Yep. So there's lots of bits to that question. So an intersphincteric fistula, the answer, as I showed you, was a lay open. It is not a lay open if you do not have the 2 centimeters of muscle, which you classically won't have in ladies, and you also won't have if they're anterior, because there is a difference in the size of muscle bulk there. But again, everyone's an individual, and your surgeon will evaluate for that. The second component is an additional bit of concern. So I came up with this analogy today, which forgive me, it is a silly analogy, but it's a stack of donuts, ring donuts. If you take a bite of one of the donuts, which is perhaps a sphincter injury due to childbirth, and you've already got that injury, and then you create your own controlled injury, which is a lay open. That's what a lay open is. We cut away the fistula and any muscle downstream. So if it's the third donut from the bottom, that's got the bite that we're going to lay open, we are taking a bite from the third, the second, and the first donut. And that again is a cut. So in that condition, I probably would want to speak to someone like Alex, a physiotherapist, get some assessment to see whether this is a sensible thing to do. I classically would therefore veer towards one of the sphincter saving procedures, of which there are many. And again, the rest of the question demands more nuance in terms of patient history and imaging and an examination.
Yeah. There was a quick question about what tertiary meant. You said tertiary referral in your talk.
Yes, apologies. So tertiary refer, so teaching hospitals associated with universities will have amazing surgeons, but occasionally they will come up against cases which are more complex. They then get sent to a specialist hospital. There are lots around the country, lots around the world. We happen to be one of them.
So it's a where a local hospital would send somebody. And then the last questions are about IBD. Is it only Crohn's patients that get fistulas, or can they come in ulcerative colitis as well?
Again, they're all loaded questions, Phil. Thank you for giving them to me as you are. So it is possible for a patient who does not have any inflammatory bowel disease to have a fistula. It is possible for a patient who has ulcerative colitis to also have that type of fistula as well, a normal, what we refer to as a cryptoglandular fistula. For some patients who develop perianal disease with a diagnosis of ulcerative colitis, they may also have developed or have been previously mislabeled as having Crohn's disease, and therefore we would organise a stream of investigations and tests to have a look and see which one they have. But ultimately, if they had a fistula with inflammatory bowel disease, the diagnosis as to which type of inflammatory bowel disease won't make a huge amount of difference, as I would probably err towards a sphincter saving procedure, and that's my difference, as well as their medication, which they'll already be on.
Brilliant, thank you. Just a couple more questions left, which I'll spin through very quickly. Hyperbaric oxygen in fistula treatment. There aren't enough data yet for us to understand how hyperbaric oxygen works and in whom, but we are starting to use it in particularly difficult fistulas, particularly in Crohn's disease. Can a fistula lead to a cancer? The answer is yes, but it's incredibly rare. Even if you've got a long-standing fistula, you're much more likely to get all the other cancers that exist than you are to get a fistula cancer. So it is not something that we encourage people to factor into their decision making. It's really unusual for fistulas to appear. Should cetons be a permanent solution? Well, they can be, but that doesn't mean that they should be. That is very much a patient choice issue. Cetons protect you from abscesses and also from surgeons. And it may be that you choose a ceton at some point, and that should always be on the list of options. But it's not the case that anyone should have one. It's a decision that a patient should make in conjunction with their surgeon. How does a fistula affect the immune system in the long term, including with a ceton? Well, probably a bit of low-grade grumbling inflammatory disease in your perineum, as with a fistula, might drive your immune system to make you a little bit more vulnerable to things, maybe. We don't have any data about it. It's not a strong correlation that we see, and the ceton doesn't seem to make any difference. It's the fistula, if anything, that would be the problem. A lot of the pictures here are of bottoms. My ceton runs from the anus to a few centimeters under the vagina. Is this more common of a rectovaginal fistula? So the answer is that it's only a vaginal fistula if it goes into the vagina. But if the fistula comes out, the opening of the fistula is right next to the vagina, then we often treat it a bit like a vaginal fistula because the symptoms can be very similar and some of the treatment options are the same. So it does depend a little bit on how it looks. Are some fistulas more associated with other conditions such as Crohn's? Yeah, more complex fistulas tend to be more likely to be associated with Crohn's disease, although you can have complex fistulas outside of it, and unfortunately many people in CAPS's 5% club do. And can I ask what you would do about an occult or hidden horseshoe fistula that's visible on a scan but not during EUA? That's a very difficult question to answer. It's one that we often discuss in meetings amongst surgeons. How do you find the tract that you're struggling to detect? The answer is you have to look very carefully, approaching the fistula from the internal opening, possibly making an incision on the outside in order to get into it where you can see it on the scan. But again, it's a conversation to have with your own surgeon. That's it for questions, Sal.
Perfect. Thanks, Phil. And we're very sorry if we haven't been able to answer your questions, but all the medical professionals, they've all got lives and families and friends, and we're very grateful that they've been able to spare their evening with us here. So again, a round of applause to everybody, and thank you so much, Kapil, Alex, Sister Denise, and Phil for joining. Now, just a quick plug, if I may. We do have our next Fistula webinar, webinar 3 on Wednesday, 3rd of July, and that's going to be focused on Crohn's, and we're going to have the wonderful Dr. Ether Shackway, who is a IBD clinical research fellow at St. Mark's, come in and talk, and we will also have Phil doing another Q&A moderation. So thank you all for joining, and we hope you enjoy the rest of the evening or whatever is left, and have a very good night, and we'll see you next time.